Welcome everybody to today's seminar. I'm really glad you can join us. I know it's the end of the third term and you guys have a lot on your plate, so thank you for being here. I'm sorry that I can't be there in person this week, but I think we're going to have a great time going over some of this research that I've been working on and hopefully some time for discussion afterwards. So I'm just going to go ahead and introduce myself today. So for those of you who don't know me, my name is Alison Gemmill, and I'm an assistant professor in the Department of Population, Family, and Reproductive Health. So I am a demographer and reproductive perinatal epidemiologist, and some of my research looks at how population health shocks, such as the COVID-19 pandemic, influence perinatal outcomes and also fertility. And I thought this was really fitting for today's session because I know that students are interested in learning about faculty's work, but also we're entering our fourth year of the pandemic, hard to believe. So I'm going to go over some of our research on this topic. All right, so let me minimize this here. Right, and I can see the chat sort of, so I'll kind of be monitoring. All right. So let's get started. So an overview. So I should have put this in the title. Today, I'm not going to be talking so much about the primary effects of SARS-CoV infection or COVID on outcomes, because we know a lot about this from a lot of literature that's out there, and specifically systematic reviews. We've seen the systematic reviews being updated constantly throughout the course of the pandemic. And in general, we know that COVID infection or SARS-CoV infection and COVID-19 disease are associated with many adverse outcomes perinatally, both for the infant and the mother. So this is, I'm just highlighting one meta-analysis and systematic review that was one of the more recent ones. And what I'm showing you here are odds ratios from their 95% confidence intervals from their meta-analyses for each of these different outcomes. And you can see elevated odds across these different outcomes. And when we look at the other systematic reviews and literature on this topic, the research more or less converges and indicates that COVID infection or SARS-CoV infection and COVID disease are associated with adverse outcomes. So I'm not going to be talking so much about this, but what I am going to be focusing on, because it's a large part of my research portfolio, are on the secondary effects of the pandemic. And we can think specifically about lockdown effects, because that's a big part of this. I'm sure we all remember how we might have felt in March 2020 and the subsequent months. So thinking about all the different ways that these secondary effects can affect both fertility and perinatal health. So specifically, what are the mechanisms that we're thinking about? So again, lockdowns are really important here, and they can affect perinatal health specifically through both positive and negative pathways. So negative pathways are probably more clear. So lockdowns were associated with increased anxiety and stress. But then they're also associated with potentially positive pathways. So we know, for example, that air pollution was reduced, at least in certain parts of the country, because people weren't on the road as much. Then we can also think about changes in healthcare utilization and screening, especially during those first few months of the lockdown when many services were closed, especially, for example, assisted reproductive technology. And then we can think about, in the case of fertility especially, economic and other types of uncertainty. So we know that when things go bad, people change their minds about having kids, at least in the short term. And then finally, rising anxiety and stress could lead to a host of adverse outcomes. So when we're thinking specifically at mechanisms that link the pandemic with perinatal outcomes specifically, we can think of these three in particular. So we know in prior research that there's strong links between maternal stress and preterm birth. So that stress or anxiety mechanism would potentially increase risk. But then we also know, as I alluded to on the previous slide, that the lockdowns might have reduced exposure to harmful environmental, occupational, and infectious exposures, and this could decrease risk. So I mentioned air pollution as a potential exposure that people were exposed less to, but also occupational exposure. So some people noted that people, especially pregnant people, probably weren't standing as much because they were working at home. And then, of course, we have lower exposure to infectious diseases in general. And then lastly, we have changes in clinical practice, surveillance, and help seeking. And it's interesting to think that this could both increase or decrease risk. So it might decrease risk, or sorry, if people aren't getting screened as much, then it might increase risk for certain outcomes, but it could also decrease risk if we're avoiding those types of interventions that could lead to adverse harmful effects. So these are all mechanisms that could be at play and hard to tease apart. So what did we know when the pandemic first started? This is an article taken from the New York Times in July of 2020. So there were reports from a few countries, from Ireland and Denmark, that were showing that there was a reduction in preterm birth in those first few months of the lockdown. So like this New York Times article says, during coronavirus lockdowns, some doctors wondered, where are the preemies? And I should add, I'm gonna follow up on this a little bit, but it turns out in the United States and in several other high income countries, we actually saw an unexpected drop in preterm birth. And I'll come back to that later. And then we also have seen a lot of research on fertility. So I'm including fertility in this talk because I'm a demographer, but it also matters for thinking about perinatal outcomes, because if something like a pandemic is changing who becomes pregnant and carries a pregnancy to term, then that's going to matter for perinatal outcomes. So this is a conceptual framework taken from Linnea Zimmerman and Celia Karp and colleagues, looking at how the COVID pandemic could affect fertility intentions, but then also realized fertility. So the crux of this conceptual framework is thinking about people's sense of security, both economic and health, and how that could influence decisions around childbearing. And then just to touch on this a little bit more, when the COVID pandemic happened, there was a lot of, or the onset of the COVID pandemic happened, there was a lot of speculation from especially the media around what was going to happen with people's decisions around having kids. And demographers know, again, that when bad things happen, usually people don't have children. So these are just a few articles from 2020 that are talking about this pending COVID baby bust. And so one of the things I'm going to be talking about today is, did that baby bust materialize? And then also what happened after that potential baby bust. And again, a lot of speculation around what was going to happen with fertility. So this is a report from the Brookings Institute by Kearney and Levine, again in June 2020, where they're estimating about 500,000 fewer children potentially, which is pretty substantial. So they say we could see a drop of perhaps 300,000 to 500,000 births in the US. And then additional reductions in births may be seen if the labor market remains weak beyond 2020. So here the mechanism driving this estimate is really about the economy. And then one last thing about fertility, I thought there was a really interesting paper that was published in 2020 that used data from Google. And the title is, here, I need to move my thing. The title is COVID-19 and the Future of US Fertility. What can we learn from Google? And so what this group of researchers did is they looked at changes over time and what people were searching for. So this is just one example. Clear blue is a pregnancy test, morning sickness. And using these Google searches over time, they estimated that births would drop about 15% between November 2020 and February 2021. And to put it in perspective, this would be a 50% larger decline than the drop that was seen with the Great Recession. So pretty substantial. Okay. So all that said, I think that was my setup. I wanted to just go into one key methodological challenge with this work, and it kind of gives you a little bit of a sense of the methods that we're going to be using throughout this talk and with our outcomes. Oops. Okay, so the key challenge is going to be about estimating the counterfactual. So those of you who have taken our courses, and many of you who do science should know about the counterfactual. It's what would have happened if the pandemic didn't take place. And of course, this is pretty difficult to estimate. And one of the things we need to take into consideration, especially when we're looking at monthly data, is temporal autocorrelation. So what do I mean by that? It means the patterning, the temporal patterning of different outcomes. So here is an outcome of preterm birth in the US from 2014 to 2020. And you can see quite clearly that there's a general upward slope. So it's trending upward across years. And indeed, we have seen this increase in preterm birth over this time. But then when we plot this monthly data, we see a lot of up and down movement. And so that is in part due to seasonality, right? In some months, we see lower numbers of preterm birth or rates of preterm birth. And in some months, we see higher rates of preterm birth. So the key, one of the key challenges is, what do we expect would happen in 2020 if that pandemic didn't occur? So I'm not going to get into too many details, but my team, my research group, we have expertise in estimating that counterfactual using what's known as Box-Jenkins routines or ARIMA models. And these models are quite special because they detect all sorts of patterns in temporal data. So not just seasonality, but also trend, plateaus, spike and decay sequences. And so ARIMA actually is, it stands for different things. So it stands for autoregressive integrated moving average. And so each one of these is a different parameter that we can model in our time series data. So I won't get into the details here, but just a quick background. If you want to know more about this, I'm happy to talk to any of you after the talk. But one thing I wanted to emphasize, so what we did is we ran these ARIMA models for different types of outcomes. So the number of births, incidence of preterm birth and extreme preterm delivery, and cesarean delivery, and sex ratio at birth. And you don't need to understand this, but what you do need to know is that all outcomes except for sex ratio at birth contained additional patterning beyond a seasonal or calendar month effect. So what does this mean? This means that when you're running a model, and if you add calendar effect dummies, there's still going to be additional patterning in some of your outcomes that's not going to be accounted for. If you don't account for that additional patterning, you could induce a spurious association. So maybe you really aren't finding a true effect. It's just maybe due to the patterning that you didn't adjust for fully. So this is something that we've argued for in different commentaries. And these are the models that we're going to be using because they fully take into account this patterning, these different dimensions. Okay. So here's what happens with our counterfactual after we use these ARIMA routines, and this is our counterfactual here. And this is going to be the basis for a lot of the results that I'm going to be showing, because what we're going to do is we're going to compare what's observed to what we actually expected, or what we expected. Okay. All right. So our first set of results are going to focus on COVID and fertility. And this is work with Jenna Nobles, Florencia Torche, and Sung-Sik Hwang. This is under review right now at Population and Development Review, and I'm hoping it will come out soon in a special issue on the fertility effects, or the effects of the pandemic on fertility. So the data that we use come from California. Ideally, we'd love to use data from the entire US, but California is one of the few states in the country that provide more recent data. Right now in the US, we can get data up through December 2020 to 2021, but in California, we have data now, at least in this analysis, through November 2022. So this is good. This gives us a long-term picture over the course of the pandemic. California represents 12% of births in the US, and it is quite diverse. So 39% Hispanic, 35% white, 15% Asian or Pacific Islander, 5% Black, and 4% multiracial. Sorry, and less than 1% Native American or Alaskan Native. So it's diverse, potentially not the external validity for some of these subgroups might not be might not be as strong when we're thinking about diversity in different states, but this is the example that we have, and we're going to go with it. So let's see. Our methods, we use interrupted time series models with monthly birth data. So what we're doing is we're using those ARIMA or Box-Jenkins models to estimate the counterfactual, and we use data prior to the onset of the pandemic. So between January 2014 and February 2020. And then the effects that we're going to look at are estimated by examining the deviation between what we expected, again, from that estimated counterfactual, and what we observe in the COVID period. And we're also going to examine heterogeneity by maternal age, parity, race, ethnicity, nativity, and education, because there might be different pathways that link the pandemic with fertility decision-making across these different groups. Okay, so here's our general picture of what's going on in California across the entire study period. This is not estimating any counterfactual. This is just showing a smooth slow S curve. And then these dots are the actual birth counts. One thing I didn't mention is we're modeling birth counts here and not fertility rates. And that's because our denominators are not necessarily reliable at the monthly, in months, especially for different subgroups that we're going to be looking at. We do run a sensitivity analysis where we do use some kind of fertility rate indicator. It's not perfect, and our results more or less kind of tell the same story. So we're going to go with our monthly number of births here. Okay, so we see one thing to note is that fertility has been declining in California, just as it has been in the rest of the US. So when we're thinking about generating a counterfactual, we need to take this ongoing fertility decline into account. Okay, so here are our results with that expected versus observed. So what we're seeing here on the x-axis are the months in our study period, so the COVID period from March 2020 to November 2022. And then what we're plotting here in blue is for all births, it's the effect estimate. So it's essentially the deviation between expected and observed. And then just as a sensitivity analysis, we also looked at births that did not involve assisted reproductive technology, and that's in the red. So what are we seeing? So we see an unexpected decline in fertility. So this would be that COVID baby bust that many people expected, starting around August, September, and ending in February of 2021. One thing to note, however, is that the effects aren't as big as what was potentially expected. So in California, it's about 5 to 6% here in these earlier months, and then about 7 to 8% in December and January. So one thing to also note is we don't necessarily see a rebound. So the rebound would be if we saw elevated effect estimates above this 0 line over here. We're not necessarily seeing that. Instead, what we're seeing is that fertility is returning to what we would expect from our counterfactual. So that's the big story here in California up through November 2022. It is really interesting, though, when we look at different subgroups because there's different patterns going on. So these are subgroup-specific analyses where the counterfactuals are estimated for each subgroup individually. And so what we're going to look at first here is nativity. So we're separating out those who are native-born versus foreign-born. Of course, California has a large foreign-born population. So this could be driving some of what we're finding. And indeed, we find that, so the way that this is, March on top and November down at here at the bottom. So we see that big baby bust, especially for foreign-born people in California. For native-born, not as much. And then maybe for native-born, we're seeing a little bit of an increase later on. So different patterns here. And I don't think I have a slide on this, so I'll just say a lot of this difference in foreign-born, it's suspected. and I think we show this in the paper actually, that it's compositional. We know a lot of people were returning to especially Mexico and Central American countries. So a lot of this is just due to people who are foreign born leaving the US. That's why we're seeing lower numbers here. Okay, so let's look at the patterns by age. So we see different stories. Let's focus here on 35 or more. Again, a baby bust. But what's interesting is we're not necessarily seeing that recuperation, maybe a little bit here, but not very strong. So this is a little potentially worrying because maybe people who would have had a kid at 35 or more are not. And so maybe their completed fertility will be lower than expected because of the pandemic. So this is something that we're going to continue to monitor. However, for age 30 to 34, maybe they didn't have that baby bust, but we're seeing some increases later on. What's really interesting, and we don't have a good explanation for yet, is what's happening with younger birthing people. So less than 25, they didn't necessarily have a baby bust, but they have this really sustained increase, which is above what we would have expected with what was going on with fertility trends. So this is something, again, that we don't have a good explanation for, but maybe it means that younger people are finally slowing down their pace of fertility delay because they have been delaying fertility pretty rapidly since the Great Recession. So maybe it's a slowdown from that. Okay, so parity, different, sort of a mixed story, we have to take into account that parity is very correlated with age. So age could be driving a lot of this. Again, the pattern that we saw with younger women or younger birthing people is kind of echoed here with first births. So we see this kind of increase in first births later in the pandemic period. Okay. Education. So one thing that we know, we separate out postgraduate degree here and college degree, and we don't necessarily see strong signals of a baby bust, but again, some increase later on. And a lot of this could be due to people staying at home, working from home, and feeling like they could balance maybe potentially having another kid with staying at home. So we see those patterns here, although for some of these estimates, they do cross the zero. So maybe they're not as statistically significant. And then one last grouping is going to be by race ethnicity. So we do see some evidence of that bust and recovery for non-Hispanic Asian. So here's the bust, and then here's what we would expect a recovery to look like. Again, it's going past that zero. We do see also toward the end of the period, potentially fewer Black births. But again, a mixed story depending on how you interpret these signals. So that is our updated fertility estimates. So in conclusion, we found a discrete short-term decline in the number of births in winter 2021, which was largely driven by births that would have been conceived in March and April in 2020. By March 2021, the number of births returned to levels consistent with the pre-pandemic trend for nearly every population subgroup examined in this analysis. And then, if anything, there is some indication of an increase in the number of births beyond the trend-based expectation beginning in the fall of 2021 and maintained through November 2022. And this is in particular for persons who are younger and primiparous. So that's where we are with fertility, at least in California. Let's see in the chat. Okay, maybe I'll take just a few questions on fertility now, and then I'll move on to perinatal outcomes. I'm just keeping an eye on time. I'll just take these two in the chat. So Linnea says, Alison, is there any evidence that restrictions on IVF was responsible for some of the decline for older women? IVF is still a relatively small amount of all births, but larger for older women. Good question, Linnea. I think, because you saw that graph where we separate out non-ART and all live births, but we didn't necessarily do that for older or by age. I want to say that I don't think it accounted for a lot, because even though it is more common
among older women. It's still a pretty small share, but it's something that I can look at in our data. So I should be getting back, I can get back to you on that. And then Asta says, is there any information on how Roe v. Wade overturn affected this trend? Funny you should say that. So Suzanne and I are working on a proposal to potentially use the same kind of approach to look at the fertility impact of Roe v. Wade, but also impacts on perinatal and maternal outcomes. So keep your fingers crossed. We don't have data yet from 2022 that could tell us anything about potential impacts yet. Oh, and then David has a good question. Overall baby bust begins in August 2020. Good, you noted that. Why would there be a conception bust in January 2020? So it turns out that we see fewer preterm births. So it's partly a story of preterm births, but then I also think potentially it's a story of earlier fetal loss. So I have a paper that looks at, I'm not featuring this here, but I have a paper that looks at stillbirths, and we see this unexpected reduction in male stillbirths in the early pandemic period. So this might be indicating potentially early fetal loss, potentially due to a stress mechanism. But again, fetal loss is so difficult to study, so this is all speculative right now. And then Kelly says, do you think paid leave policies influenced younger age groups in not delaying pregnancy? I don't know if they paid leave policies necessarily were in place here, but I might be, I'm not sure. We don't know what's going on with the younger age groups. So if you think that that could have a role, I'd love to hear more about that. So feel free to let me know. And if anybody has any other thoughts about what's going on with the younger age group, yeah, let me know, because we don't know what's going on. Okay, good questions. I will move on to perinatal health now. Because I think these findings are really exciting too. So this is COVID, and I'm going to first talk about more understudied perinatal outcomes. I already mentioned preterm birth, so I'll get back to preterm birth soon. But I wanted to focus on outcomes that are potentially harder to study because they're not necessarily measured in birth certificate data or other types of data where we can monitor outcomes, via surveillance. So this is joint work with Deb Karasek, Rita Hamad, Daniel Collin, and Caitlin Jackson. Oops. Okay, so these are the outcomes that we're going to focus on here. So during pregnancy, we're going to look at prenatal care utilization, gestational weight gain, which can be measured in the birth certificate, but we're going to use a different data source here. Gestational diabetes, high blood pressure in pregnancy, and then depression during pregnancy. And then during the postpartum period, which we cannot use the birth certificate data at all, we're going to use any postpartum visit, postpartum depression, breastfeeding initiation, and breastfeeding duration among those who have ever breastfed. So we're not using birth certificate data, but we are going to use data from the Pregnancy Risk Assessment Monitoring Survey, or PRAMS, from 2016 to 2020. Sorry, let me just take a sip. Okay, so for those of you who have taken my class or our classes, you might be familiar with the Pregnancy Risk Assessment Monitoring Survey. So this is a follow-back survey that samples birth certificate data and then interviews those birthing parents about 4 to 6 months postpartum. These are run by states and then aggregated by the CDC. So for this analysis, we're only including participants from sites or states that participated in all available years or that released data for all available years. And then we restricted our analyses to live-born singletons. So we have about a sample of 116,000 or a little over 116,000 births. So what we do here is we conduct, again, this interrupted time series analysis on monthly aggregated outcomes. So we're going to aggregate the PRAMS data according to the month of birth. And then we also going to here use some covariates at the aggregate level. So the percent of birthing parents that were Black, the percent with less than a high school education, et cetera. So I just want to note this is an aggregate test, not an individual level test. All right, so let me show you what these outcomes look like. It's gonna look like this for all our outcomes. So let me walk you through this graph.
So this is again showing observed versus predicted. We're estimating our our predicted is the counterfactual. We're estimating that post March 2020. And then we're just looking at deviations again in observed versus predicted. We ideally want this to be white noise back here. And then this is what we're estimating, to look at our effects. And so what we see here is 9 or more prenatal care visits. So we see this decline after the pandemic. And overall, so the overall effect would be from March 2020 to December 2020, we're seeing a drop in 4% with a little bit of variation by race ethnicity. So Hispanic were more likely to see a larger decrease here. So this is just one example of this outcome that we're looking at. And I should mention, so the graphs that I'm going to be showing are unadjusted. So some of them might have some temporal autocorrelation that's not accounted for, but in our fully adjusted models, which is what you're going to see here for the overall effects, that's all taken care of. So this is really the overall effect here. All right, so here's gestational diabetes. In the middle of the pandemic and toward the end of the pandemic in 2020, we are seeing this increase. So overall, we're seeing a 21.6% increase with larger increases among Black and the other racial groups combined. Okay. Gestational hypertension, we see this upward trend again in the overall model. This upward trend is accounted for. Sorry, I wish I chose other graphs here, but I didn't have them available. But anyway, the main story here is that we see about an 11% increase in gestational high blood pressure in pregnancy. This could include all different sorts of hypertensive disorders in pregnancy. We see larger increases for the Hispanic birthing population and not so much for the other groupings. And for gestational weight gain, we don't really find any association. So overall, not significant. And then depression in pregnancy, in our full model, which adjusts for this upward trend, we do see a 16% increase in depression during pregnancy. So this is based on women or birthing people saying that they were diagnosed or received a diagnosis of pregnancy or depression during pregnancy from a healthcare provider. We see greater increases for white, Hispanic, and other, not so much for Black here. And then postpartum visit. This one just like really jumps out, and it's perhaps not too surprising. So here, actually, we did adjust our shock to January 2020 because we think that births from January 2020 on are going to be more likely to be affected by the lockdown. So this is definitely a lockdown effect. It's really easy to see that. So here we're seeing a large lockdown effect with those initial birth cohorts, but then it goes back to normal at the end of 2020. So the overall effect for the entire pandemic period is pretty modest. But if we look at these earlier birth cohorts, it's much stronger, obviously. Okay, and then lastly, postpartum depression. So we are not finding any association with postpartum depression. Again, we're just going through December 2020. There might be some indication that later on things might be, there might be an uptick toward the end of the series, but it's all speculative right now. So again, no association with postpartum depression up through 2020. Okay, so these graphs look a little different, but they're showing the same thing. It's because this is for a completely different paper on breastfeeding. So this is for breastfeeding initiation. In the overall sample, we don't really see a big change with breastfeeding initiation. There might be something going on in these earlier cohorts, but it's not consistent here, maybe for this one right here, but who knows? Could be due to chance. And we did, however, find this exception of decreased initiation among Black respondents with a 5% decrease. However, we did find this increase in breastfeeding duration among infants ever breastfed. So in the overall sample, breastfeeding duration increased from 12.6 weeks for births that occurred pre-January 2020 to 14.8 weeks, which is an 18% increase for those that occurred during January through February 2020. Now, keep in mind, I forgot to mention this, or maybe well, let me just be explicit here. This is interviewing birthing parents at 4 to 6 months postpartum on average. So it's not breastfeeding through the entire period of infancy. This is just breastfeeding up to the point at which they're interviewed. But we did find that the increases are largest for white respondents and they're smallest for Hispanic respondents. So I have a few thoughts on this, but let me first just get to our conclusions for the PRAMS analysis. Looking at our time, okay, good time. So the onset of the COVID-19 pandemic resulted in decreased prenatal and postpartum care utilization and increased prevalence of gestational diabetes, gestational hypertension, and depression during pregnancy. We did not detect differences following the pandemic in gestational weight gain or postpartum depression. We've not yet looked at the role of telehealth. PRAMS did include a module in late 2020 asking people about their experiences with telehealth, but we're not sure how to incorporate it because the data are not regularly collected across states. And then what's interesting, I think, is that the results for gestational diabetes and hypertension persist after adjusting for potential compositional changes, which suggests that these effects are real. I don't yet have any great insights around why this might be happening, but this is ongoing work, so we're going to be digging deeper into these impacts in the coming months. Okay, so let me just finish with one last set of analysis. Oh, wait, breastfeeding. Yeah. So the breastfeeding results are really interesting, I think, because they suggest a substantial pent-up demand for breastfeeding, which might be stymied by the lack of a national paid family leave policy in the US. And there were no changes in the breastfeeding initiation in the overall sample, which suggests that barriers to begin breastfeeding may differ from barriers to breastfeeding continuation, which we kind of know about from other research, but it's interesting to see that echoed here. The gains were larger among white and high-income respondents whose jobs could more easily be carried out at home. And it suggests that rates of breastfeeding in the US would be higher and more comparable to peer countries if working parents were able to stay home with their infants, and highlights the need for careful design of paid family leave policies to ensure equitable access. So this paper is currently a revise and resubmit at American Journal of Public Health, and we hope it eventually gets accepted because it has important policy implications. So yeah. One more thing before I move on to the last set of analyses. We have studied pregnancy-associated deaths due to the COVID pandemic. And so pregnancy-associated is not just due to obstetric, but due to other causes. So this was published, I think, last month. So we know that obstetric-related deaths, so maternal deaths, have gone up about 28% between 2019 and 2020. It's much harder to run the kind of ARIMA analyses that we did because the deaths are very few, and usually we have to use annual numbers. So just keep that in mind. This is just comparing 2019 to 2020. But what was interesting is that when we look at these other causes that are not obstetric, we're seeing pretty big increases in drug-related and homicide-related pregnancy-associated deaths in the US. But suicide has actually gone down. So pregnancy-associated suicide went down in 2020. And some of these patterns sort of match what's going on with the general population. We are about to get our hands on the 2021 data so we can see if these patterns persist. And right here, I'm just noting that there was about 400 additional deaths in 2020 compared to 2019 for these overall pregnancy-associated deaths, which include all causes. Okay, so last bit of analyses, which I'm going to just spend the final few minutes going over. I think the big question is around these population level perinatal effects after 2020. So much of our data has been delayed, but we finally now have the 2021 birth certificate data.
So like I alluded to before, in 2020, we saw this unexpected reduction in preterm birth. The line here is what we would have expected. And then we see our observed dots in black. Anything covered or colored in black means that it was statistically significant. So overall, we detected this 5 to 6% reduction in preterm births in 2020. And then here, I'll just go on. So the big question is what's happening after 2020. So here are those same types of models we're using with birth certificate data through 2021. And we see those reductions here in 2020. And then we see a spike in January 2021. And that is the Omicron pandemic, or the Omicron epidemic. Yeah, pandemic virus. What am I trying to say? Variant. That's the word I'm looking for. And this has been seen in some other work by some colleagues of mine. I'm using data in California. So this is really where we're seeing the negative COVID effect with the direct effect of the pandemic because of the Omicron variant. Oops. But then it looks like things might be getting back to some kind of normal after that. So maybe things are stabilizing. Low birth weight. We saw the reduction in low birth weight again because we saw fewer preterm births. This makes sense. Then we see this increase in low birth weight again because of the Omicron variant, and potentially still remaining high throughout 2021. And I should say this is work in progress, so we're still refining these models. So you guys are the first to see these. Small for gestational age. Some decline, well, it's not statistically significant necessarily, but maybe something's going on here, and then maybe some increase, but again, maybe there's nothing going on because it's not statistically significant. But what's interesting is that while I do think that you should not necessarily study or use gestational diabetes and hypertensive disorders of pregnancy from the birth certificate because they are just very error prone, if we assume that those errors are regular over time or the same over time, then maybe this is picking up on real trends. I'm not sure yet. This is just something I wanted to show because we are seeing this increase in gestational diabetes that was mirroring what we saw with the PRAMS data. But what's interesting too is at the end of 2021, maybe we're seeing the decline back to baseline. Hypertensive disorders of pregnancy, not much going here, at least with the birth certificate data. All right, so I think I'm almost done. So next steps, we're going to continue refining results from the 2021 birth certificate data, including variation by subgroups. That's what we're working on right now. And we're thinking about examining county and or state heterogeneity, thinking about do policy climates moderate these relationships. And we are anxiously awaiting the PRAMS 2021 data. So all the PRAMS analyses that I showed you here go up through December 2020. And that's the end of my talk. I just want to acknowledge the funders for this work. So thank you. And because I'm moderating it, I will need help to get questions from the in-person audience. So if there's any students from the audience, I see a student in the chat. So Jess says, do we know if telehealth visits were equally likely to be counted as prenatal visits as those that occurred in person, or what counted as a prenatal visit in the data you used here? That's a great question. I think it's up to interpretation, and it's something that we should be looking into a little bit more with the data that we have on telehealth, which is not perfect. I wish it would be a little better, or it was better. So that's a good question. It's possible that people who did receive a telehealth visit would consider that as one of their 9 or more prenatal visits in the data that I showed. I'm going to write some of this stuff down. All right, any questions in the audience from students?
Adrisha, I had a question about some of the next steps, especially the policy climate. I was wondering for that, are you looking at any policies that went into effect in California during the pandemic, or are you looking at comparisons between policies that already existed in California versus other states that didn't have that kind of policy?
Yeah, so for the policy part, we could look beyond California because this data that I'm showing here is for all states combined. So sorry if that wasn't clear. California was just for the fertility analyses. So one of the collaborators on this work is Rita Hamad, and she is a big policy person. She currently has an R01 grant looking at the impact of different policies on COVID-19 mortality. And so we are thinking about extending some of that same kind of, or those same policy exposures to think about how those might moderate these associations that we're seeing. So this is like really in the early stages of development. We're thinking about putting together a grant to look at this. And then we did include counties because it might be for more populous counties, we can look at specific county level policies that might matter here. But I don't have like off the top of my head the types of policies that we're going to be looking at. So yeah, we have different policy climates, but then we're also interested in the implementation of specific policies during COVID. So this can go in many different directions. And we're not sure yet which direction it's going to go. So good question. Should I take some of these from the chat?
Yeah, and then we have some questions in the room also.
Okay, so Elizabeth Gumerson says, we found in a systematic review that younger women were more likely to struggle to access contraception and abortion services during earlier phases of the pandemic than older women. That might contribute to it. Yes, good point. So we didn't want to get too speculative in our write-up of the results for the younger women in fertility. So one of the good things about PRAM's data when the 2021 data come out is that it does ask about unintended pregnancy. And so I have a planned analyses ready to go when that data comes out to look at changes in unintended birth and contraceptive failure. So that's something I'll be looking at. It doesn't quite get at, of course, all the dimensions around people's reproductive decision-making during and access to reproductive services, but I think that might tell a little bit of the story. Okay, Sally, wait, I just lost it. Sally says, oh, wait, I lost it. Oh, and Sally says, for younger ages, I was wondering if finances might play a role. People had money to save during the pandemic, maybe that financial cushion. Yeah, I think that's a great explanation too. So something that can be investigated. Great. And I'll take one more here. So Dana says, oh, you guys are, thank you for all your speculation around younger people. Maybe for younger people who were able to keep their jobs during the pandemic, lots of people lost their jobs. Wonder if looking at age X income or age by income or education could provide some more detail. Yeah, these are all great. I'm saving this chat. Thank you. All right, we can take, there's more questions here, but we can take some from the audience.
David?
Oh, thanks, Alison. Great. Regarding the decrement in preterm birth, it's interesting that the reciprocal is the increase in diabetes, which could lead to increased birth weight. Actually, false assumptions regarding that birth weight, but due to the maternal diabetes. So that reciprocal is interesting. The other thing is with respect to early fetal loss, there may be a problem. We know with Zika, there were problems, and that may enter into the picture. And the underrepresentation of Black population, of course, may, I think you had 5% in California.
Right.
Which is about is a low percentage in terms of that, and of course with Hispanic you have an increase in birth weight frequently. One other small note is regarding the breastfeeding in terms of the similarity and the term you used, ever breastfed, is the WIC term that's used, and of course WIC was maintained during COVID. Due to waivers and all of those things, and you may get some increase or let me say, no decrement in the ever breastfed population because they continue in terms of tele-WIC. So,
Oh, okay, we could include that.
points to think about. But thank you. Very interesting.
Thanks for those helpful comments. That's good to know about WIC, because maybe we can include some, we can allude to that in our discussion to say like, hey, maybe this helped buffer against a potential decrease in initiation.
A lot of your analysis telepaths.
Yeah, great. So I didn't include large for gestational age here, but we are seeing an increase in large for gestational age that like you suspected might be increasing with the increase in gestational diabetes. So yeah, great. So Pam in the comment says, there were formula shortages during the early pandemic. Do you think these shortages may be related to breastfeeding duration? Oh, good comment. So I don't know exactly when those formula shortages happened, but this is something that we should definitely look into. So thank you. And Donna says a similar question as Pam asked. There was considerable competition for healthcare resources during the pandemic and changes in where and how obstetric resources were provided. What do you think might have been the impact of this competition? So Donna, are you talking about pregnancy care in general or for breastfeeding? Or maybe there was a question that I missed. I don't know if Donna.
Sorry, I was talking more about the fact that pregnant individuals were very worried about delivering in a hospital. There was considerable competition because much of the resources were being shifted in care, particularly intensive care and a variety of other services, to the pandemic. And there were changes I know at Hopkins, there were changes in where the obstetric services were available. So I'm really talking more about labor and delivery.
Okay.
But it seems to me that that's a huge issue that confounds this analysis and the reluctance of individuals to even go to a healthcare setting or to even deliver in a hospital. And just having had the experience with my daughter-in-law giving birth in September of 2021, there was still concern at that time, and there was limited visiting and other factors that you think of normally that goes along with grandparents visiting and everything. So, I mean, it seems to me that's a huge issue when you're thinking about some of these analyses.
Yeah.
And particularly maternal health analyses.
Well, so are you thinking that instead, Laura, I'm missing people that had home births, for example?
No, I think what's happening is I think that what's happening is for individuals who experience complications, and you've got sort of you got this increase in at least obstetric related maternal deaths that there could be related to that competition.
Yeah, no, I completely agree. Yeah, it's something that we can definitely embed in our write-up of these analyses, and we just need to be more address that in our papers. I mean,
yeah, the other thing to think about with the large for gestational age analyses is that if there was less induction going on, then you might see an increase in large for gestational age births that are independent of the diabetes. And you know how I feel about diabetes, those data from birth certificates. So
I agree.
But I do think that there may be, that these obstetric changes have some effect that need to be sort of thought about, particularly when you're thinking about like something like large for gestational age, because if there's less induction and you've got birth certificate data to possibly look at that, then maybe that's the reason. I just wanted to make one other comment, which I made in the chat, that is that, you know, when you look at your range of the values that you present, it's a very small range. And I just think when you're looking at, so when I'm looking at the preterm birth rates, they exaggerate, I think, the changes that occurred over time. You know, you're not looking at the full range. You were looking at like 0.88, 0.08, I think or 8.9 to 9.8 or something like
Yeah,
that. So,
right.
I think they over dramatize the change, and that's not a criticism necessarily, but maybe something to think about when you talk about the results, because you don't want people to walk away and think, oh, these are huge changes, when they're relatively small changes.
Well done. Like, so for the reduction though, that we saw with preterm birth, it's the same impact as this increase in preterm birth from 2015 to 20 when we quantify it.
Right, but I'm just saying either way, none of them are really large.
Okay, yeah, because you're going from 9.5 to 10.
Right, because when I
yes.
show that graph, when it's the full range, there's a slight
sure.
increase, but it's
Sure.
not a big one. Yeah.
Yeah. Fair point. Yeah. Yeah. So I'm.
Oh, and by the way, wonderful job. I agree with Pam. I didn't want to sound like I was criticizing the work.
It's totally fine. I think what's really where we are right now, we got our hands on this 2021 data. And some of the people that I work with are like, especially those that are more thinking about, using econometric models and policy change. They're like, oh, I throw all my outcomes into the same analyses and we'll just write these up. And I'm like, well, maybe we should think about, different conceptual models or frameworks for these different outcomes. And like you just said, with large for gestational age, thinking about the role of induction is really important. So, yeah. All right. So any other questions? I think I got almost all of them. Yeah. Oh, wait. And then there's one more in chat that I missed from Ian. Yeah. So in the room.
Yeah. Hi, Allison. Great talk. Just one note about the breastfeeding initiation. You showed this big dip in initiation early on, and they were separating moms and babies at the beginning of the pandemic. Which made breastfeeding initiation really hard, as well as moms were not allowed to have a person with them. So if they had originally had a doula or someone else who was a role model to help with initiation, it was not happening. So that's like one thing to think about. The formula crisis started in February of 2021.
Yeah, okay.
And that's when WIC started having problems locating formula. The big crisis came a couple months later for everyone, but it started in February 2021.
Okay,
So,
thank you. So it wouldn't explain this yet. Yeah. But
I think it's staying at home and being at home.
That's what we think too. You said something. Oh yeah. So the separation of the infant and the mother, and then also, the different supports. So it's interesting. So like I said, PRAMS has this COVID module that they started introducing in late 2020, and different states took it up. And for those of you who are interested in this, I mean, the COVID module asked a lot of questions around, who did you have supports during childbirth? Like, was your partner allowed to be with you? And then experiences with telehealth. We haven't looked into those questions because I assumed by now we'd start seeing papers that are using those data, but I haven't been seeing them. So there might be like interesting analyses to do just with those COVID related questions. It's interesting too, because it looks like they didn't ask those COVID questions in 2021. Instead, they switched to a new module on the COVID vaccine. So, but a lot of interesting secondary data potentially for research opportunities. So great.
It's also just to think about the need for support, to think about the shortage of personnel during that time, so that even though maybe the support for breastfeeding may not have been as much of a priority if there's limited staff.
That's true. Yeah. Okay, great. And then I see one for a question from Ian. And this is about fertility. Is there evidence on frequency of sexual activity for younger ages? Lockdowns may have meant less opportunities and or lower interest for groups registering baby bus. Yeah, so I think in general, There's
Always
been
that could
studies
be.
that have shown a decrease in sexual activity following or with the lockdown, but again, could be heterogeneous depending on whether you were in a partnership or not. So yeah, that's definitely one of the mechanisms that that people mention when talking about fertility effects. Also, just opportunities for meeting people to engage in sexual activity. Yeah, so yeah, you say opportunities there. So great. So any other questions? I see another. Okay. But hopefully it was a lot of food for thought. Like I said, a lot of these are working papers and analyses. So yeah, and if anybody is interested in potentially working on these projects, let me know. So the PRAMS data does have data restrictions, so that is a little challenging, but I'm willing to put in another application for the 2021 data, for example, and then yeah, the NCHS birth certificate data are publicly available. So great. Thank you,
Thanks very
everyone.
much.